introduction. Okay, I want to make sure I know how to use the pointer. As Dr. Hansen said, tonight really we want to make sure that we communicate with you all, get an idea about what your questions are, and if we can help answer some things that maybe have not been answered for you in the past, whereas tonight, particularly my talk, is really just a flash of some of the work that we're doing. I'm not covering probably 80% of our research, but I thought this would give you some overview, and some of the things I'll be mentioning will be touched more in depth by some of our other presenters tonight. So just in terms of basics, ADHD is a disorder where children and adults display more activity than one would expect for their age. They might have more difficulty sustaining attention, greater impulsivity, and so forth. And again, it's really key to say that it's developmentally different from what you would expect for their age. Now, not everybody displays all those characteristics. Any one of those or two of those could result in the diagnosis, but it has to be different from what you would expect from their age. ADHD is oftentimes associated with academic problems as well. We'll hear more about that from Dr. Breslaw. Relationships are affected for children, whether it be their friendships, with their siblings, with their parents, as well as for adults. That could be with their spouse, it could be with their coworkers. We recently published a study, this is with a former graduate student of mine, Russ Hanford, and a more recent student, Megan Miller, where we found that adults with ADHD, particularly the inattentive type, had a really hard time reading nonverbal cues, and perhaps that's one reason that their social relationships are affected. Caregiver burden is also another huge issue that goes along with ADHD. It's not just a difficult problem for the people with the ADHD, but those in their environment as well. So for instance, you could have a perfectly wonderful mother and father with a child without ADHD. You put that same parent with a child who does have severe ADHD, and their parenting skills change. So it's not just a unidirectional, it's actually that the child affects the parenting skills as well. So this creates immense emotional difficulty for some families because it is such a challenging disorder. Along with the ADHD, we find that frequently there's other issues that appear. Oppositional defiant disorder is essentially when a child says, no, I'm not going to do it. So it's not that they're just not listening or paying attention, they're actually defiant. And that's very frequently occurring in ADHD. But we also find conduct disorders are also much more prevalent. Conduct is much more severe in the sense that it might be somebody is stealing, somebody is hurting animals, and so forth. And that tends to occur more in males than females with ADHD. But mood disorders, anxiety, learning problems are also very common. And so all those issues need to be addressed as well as the ADHD. You have to really look at the whole person rather than just one issue at a time. This is just an example of some of the research that we've done. Working memory is a particular area of interest of mine for many years. And I think I got really most interested in it because of some of my interactions with my patients. So when I was seeing some of my adult patients, I frequently would have one spouse say, well, it's not that I'm impulsive when I interrupt you all the time. I'm interrupting you because I'm going to forget what I'm going to say. And so I thought, well, that's a memory issue. And the spouse sometimes believed that and sometimes not. Sometimes they really thought they were just being impulsive. But we know now that working memory tends to be one of the most common cognitive problems that people with ADHD encounter. For the child in a classroom, it might be that they're trying to take notes while a teacher is talking, so they have to listen to what the teacher is saying and take notes at the same time. So you're taking in information and you have to manipulate that, and that's difficult. So what we did is we looked at this in the scanner, and this first study was many years ago, and that was published in 2000, and we found in adults with ADHD, and this study down here shows that these are the control subjects and these are the ADHD, that they use very different regions of the brain to perform working memory tasks, but also by report from them, they use different strategies. So for many of our people, they suggested that they use visual strategies rather than verbal strategies. So for instance, if you were given a phone number to remember, a verbal strategy would be repeating it to yourself. Many of my subjects reported that they saw the numbers, and this is when their eyes were closed, so they were using a visual strategy. We replicated the study in a larger sample in 2004 and showed again that the healthy controls use regions of the brain, the frontal cortex, temporal lobe, and so forth, that are oftentimes linked with attention, executive functioning, and verbal strategies, whereas the ADHD group tend to use more motor and visual regions of the brain. So this was what we found in adults. The question is what happens in children? Because adults maybe have learned some compensation strategies, and these children also probably may have, because some of these were ranged from age 8 up to 12. So ultimately, we really like to look at much younger children. But again, we found similarly to what we found in adults is that typically developing children tend to use the frontal cortex much more when doing a working memory task, and they deactivate it, so they shut down some regions of the brain when they're doing working memory. Whereas the ADHD group did not use those regions of the brain, but instead they used some other regions. And this region of the brain here is called the insula, and it goes into the claustrum. These are just different views. So this is a view sliced this way, and this is a view sliced this one here, sliced this way in the brain, and this is a view sliced this way. And these are all sliced this way, if you can imagine. And this insula part of the brain, this is a part of the brain where information is integrated and it's used in evaluation. And we also think it's a link between emotion, reward, and decision-making and thinking. And so it turns out people with ADHD are using this region of the brain more, but it's not just during working memory. They're using it even during attention tasks that aren't quite as difficult. So what we are hypothesizing is that they're ramping up these regions of the brain when they know they're in a challenging situation, even though they're not using it specifically for something that's maybe even more challenging, such as working memory. So it's sort of an indiscriminate use, and it's not a very efficient use. And that's why I think sometimes when I see children with ADHD who are very tired after doing some of their homework, even though it may not be very difficult, I think it's because they have a difficult time discriminating between what's the most difficult targets to key into versus those that are not. I oftentimes think it's what we call a signal-to-noise problem, identifying where they really need to focus. And so again, they've got this overactivity, and sometimes when they don't need it, and I think all in all, again, this could lead to more frustration, probably why we see the insula activated, this emotional part of the brain. So this is another study. This is a collaboration with Sharon Coffey-Carina, who's here tonight in our audience, and Dr. M.I.N.D. And this is really a study that's led by Dr. Fassbender, who will be up here later. And this is an example of how we're looking at subtypes, because ADHD is such a broad category, but we know not everybody with ADHD is the same. And so our idea is that if we can look at subtypes of people with ADHD, perhaps then we can also identify treatments for targeting, treatments that target those specific issues. So this is one attempt at that. And this is using something called ERP, or event-related potential. It's an EEG where you present stimuli to the individual, and these are called heat maps, what you see down here. And so these are TD is typically developing children, IA is inattentive, and CO is for combined. So inattentive means they just have problems sustaining attention, filtering out distractors. The CO means they're inattentive, impulsive, and distractible. And in this particular analysis, what's being looked at is how children with and without ADHD respond to cues. So they're given a cue that's told they're going to have a difficult problem coming up, and that cue should be a way for them to neurally think, okay, I need to boost my attention, I need to pay particular attention because there is something challenging coming up. And the question is whether or not these individuals show a difference neurally. Again, you can imagine in a classroom, that's just like a teacher saying, okay, I want everybody to focus because now it's going to be something really difficult. I want you to pay attention. And so what we see is that with the typically developing children, you see a large change in their electrical activity. So they are noticing, they are responding to that cue, but you don't see that as much in inattentive, and you don't see it hardly at all in the combined type. And this is another way of looking at that. Here's the typically developing. So there's this big difference in the waveform here that they're really noticing and paying attention to that cue. Now this is something completely different, but again, tonight's part of what we're doing is showing you the array of what we're looking at. This is a collaboration with Dr. Lisa Litt and Dr. Frank Sharp, and collaborators of theirs from Cincinnati. And where they're looking at gene expression. So I don't know how many people here have participated in our studies, but oftentimes will say that if they're willing to participate, we have a study where we are looking at gene expression, and you get $100 for a blood sample. And we get lots of people, lots of children even, volunteering for that. And what we're trying to do there is look at whether you can, again, do some subtyping, but this is according to different diagnoses. So earlier I talked about how there's a lot of people with ADHD have more than one diagnosis. And so Tourette's is a particular area of interest of Dr. Sharp and Dr. Litt. And what they do is they look at if you have Tourette's and obsessive compulsive disorder, that's the OCD, and ADHD, if that's expressed differently in blood. And indeed, they find if you just have one disorder versus you have more than one, it looks like it's expressed differently. And again, this leads potentially to think about that treatments might be different for those who have more than one. And so that potentially could lead to different ideas for treatment development. I'm not going to show any data here, but this is just for some people to think about. This is a collaboration that we've been invited to join, and it's called the 200 Sample Connectinome. And this is a collaboration between 5 and more institutions from China to us. It started actually out of NYU, Mike Millam and Javier Castellanos, Damian Fair up in Oregon as well. And the idea is that if we're going to optimally use brain imaging, we have to gather large data sets if we are going to do robust look into genetic reasons for ADHD and other issues in terms of how to subtype them perhaps. So our goal, right now they have over 200 samples. The goal is to get over 1,000 samples and join these data sets together. And this is something that we're seeking funding from NIH and NSF in the future. So just for you to see that science we feel has to change, and that we have to be more collaborative and use more of a team effort if we're really going to make these big strides in the future. And this is in terms of our laboratory and our program. Just again, some of the goals that we've listed. I talked about some of those. We're looking at genomic uses and processes and genetics. Dr. Lisa Litt has a great study where she gave dog owners the ADHD rating scale and had them rate their dogs to see if you could actually categorize dogs according to the ADHD symptoms, and she found you could. This is almost, I think, 1,000 samples people reported. And I know there are some people out there, I'm sure, who say that their dog has ADHD. And this is important because we do have animal models for ADHD, but most of them tend to be mice or rat models, which is very common in psychiatric and neurodevelopmental disorders to have those models. And those models are very useful, but they're limited in terms of their social behavior and their behavioral repertoire. And as a geneticist, Dr. Litt feels strongly that the canine model offers us more in terms of how we can look at their behavior and how it relates to their genetic development. So I'm hoping that she continues in that line of research. As I mentioned, we're doing a lot of work in brain imaging. We're looking at a lot of behavior and how these all correlate together to see if we have a better idea if what you see in a brain imaging study has something to do with real life behavior and how we might learn about, again, treatments for that. Clinical interventions is an area we've really focused on for the past couple of years, and Dr. Dixon's going to cover some of that, and Dr. Pakarak as well. We've been looking at how we can spread parent training, parent education programs through telemedicine as one way. This is former, Dr. Shi was a former child psychiatry fellow we had here who did a study on that. You'll hear more about our cognitive training and working memory. And a long-term goal is to look at whether we can use cognitive training with pharmacotherapy, so with medication, to see if that makes a difference. And then tonight you'll also hear about epidemiology and how we can use epidemiological approaches to help us look at targets for our research in the lab and how we can look at from large population samples. Back down. Now I'm not going to go into all these names, and this isn't everybody, but this is just a sample of some of the most recent people who have helped us. So to do the sort of work that we do requires a lot of people and a lot of talent and a lot of work. And we've been very fortunate that we've had a great group of people at the M.I.N.D Institute, and we've had some tremendous collaborators at University of Maryland, at Stanford University. Stan McClure, we work a lot with him. He's actually a behavioral and neuroeconomist. And there are people actually throughout the country who help us in our research. So when you see our findings up here, it doesn't really just represent just our lab. It represents a much wider group of people. And we believe in science. That's the way to move forward, is people to work together in teams. So I've probably taken more than enough time. So with that, I would like to introduce Dr. Breslaw, who's a psychiatric epidemiologist here.
Thank you. Thank you, Julie, and thank you all for coming. I'm just very briefly going to present some of the epidemiologic work that we've been doing. I'm a psychiatric epidemiologist. Actually, I never intended to be an ADHD researcher, and the reason that I'm here is because of findings that I'll be discussing shortly that kind of led me to ADHD from a very different direction than I think everybody else came to. So this really represents a convergence. So what is epidemiology and what's our approach? Epidemiology is the study of the distribution, causes, and effects of disease in populations. It's very much a population-based science. And I've highlighted two words here that I want to say a little bit more about. What do we mean by population studies? How should we think about that? This is just shows you, think about just conceptually, if we think about how much information, if we have a certain amount of money to do a study, and we want to take, we have to balance how much information we get per person versus against the number of people we have in our study. The more people we have, the less we are able to get a lot of information from each individual. We think of the brain imaging studies that Julie was just describing. We're up in that region of this graph. We're getting enormous amounts of information from a relatively small group of people. Our epidemiologic work represents the other end of the spectrum. That is, we are dealing with samples of routinely of hundreds, if not thousands or tens of thousands of people. But of course, in that means we're much more limited in how much information we get from each individual. But nonetheless, trying to bridge these two approaches and to build some bridges between them and some feedback from one to the other. Now, we're also looking at effects of disease. You're probably much more familiar thinking about research where we're looking at risk factors for disease, where disease is our outcome. In this case, actually, we're starting with the disease as our exposure, and we're interested in, well, what does that disease cause? So the disease is the cause and not the effect. But really, other than that, all of the methods that we use to look at this are basically the same, just kind of switching the variables around. So why do we do this? Our epidemiologic work is essential for understanding the public health significance of health problems that we see clinically, for actually gauging, well, what's going on out in the community, understanding what's the magnitude of the problem, where is the problem located, both geographically but also socially, where can we get a grip on the problem. And also trying to understand issues of causation. So for instance, we're thinking about the effect of ADHD on educational performance. As Julie mentioned, we have an enormous amount of comorbidity in ADHD. And the same is true of virtually all psychiatric disorders, and it's particularly problematic in children, where one day they might look like one way and another day they look another. So trying to sort out which type of problem has an impact on education really requires that we go into large samples and that we go into population-based samples where we don't have people who are simply the people who are showing up to treatment who may not be like those people who are out in the community. And also thinking how that helps us figure out how we can intervene. So what about ADHD? ADHD is a common disorder, so if there are widely ranging estimates of the prevalence of ADHD in the population, ranging from, say, 3 to 9%. And can you imagine if 9% of the children in Sacramento showed up at the M.I.N.D Institute for treatment tomorrow? We'd have a problem. Highly comorbid with other disorders. And our problem in epidemiology, again, is how can we isolate the effect of ADHD from other mental problems? We might also think about other kinds of social background factors also that we have to try to control for, to adjust for, to say, well, what is it? Is it really the ADHD, or is it some of these other things that are associated with ADHD? So what have we learned? What do we think that we've learned so far? Well, at the start of schooling, so we're talking kids going into kindergarten, first grade, there are already wide differences in kids, not only in their preparedness for school and how well they're coming into school on the first day, but also in a wide range of mental health problems that include attention problems like in ADHD, but also conduct, externalizing behavior, acting out, anxiety and depression. So there's a really, already coming into school, there's a wide range. And in studies that have looked at tried to look at this whole broad range of mental health problems in kids, 5, 6, 7 years old, and what happens to them in their first years of schooling, say through the end of elementary school. What they found is that there's actually not a lot, that the mental health problems don't have a big effect on how kids are doing in school. That is to say, like their test scores in 6th grade, with one exception. And that exception is inattention, is the problem of inattention. So that, which is really surprising. So when I say that, like, I did not set out to be an ADHD researcher, but was led to it, it's findings like this that have led to the focus on ADHD, because we're concerned about, well, this is something that we really need to focus on because it's starting to have impact on kids that can have lifelong consequences starting very early on. So what happens in adolescence? So we've looked, up through, so initially we were looking up through end of elementary school, but a lot happens. It's a long and winding road between there and young adulthood as kids go through adolescence. And what happens over that period? So we had a study, a longitudinal sample of about 800 kids who had been followed from age 5 all the way up to age 17. And we asked the same question that they asked in the earlier study with respect to elementary school, which is like, which of these multiple mental health problems affect test scores? So, how kids are doing their math achievement, their English, their language achievement at the end of high school, so following all the way up to age 17. And basically, we found exactly the same thing, that this pattern of the early attention problems really being very distinctive and having an effect that shows up in kids' test scores here 12 years later, so from the beginning of school to the end of high school. And further, that some kids who improved during that period, if their attention improves during that period, well, their achievement actually also improves during that period. And kids who go down in attention also, we see a negative impact on their test scores. Now, high school dropout is the other thing that we're interested in. So the previous studies were on test scores, which is one thing, and it's important to look at particular kinds of educational outcomes. High school dropout is another. And really, high school dropout, or on-time completion of high school, is probably the most significant milestone of adolescent development. Hard to think of a single more important milestone. And we looked at this in a national sample of adults. We actually had 40,000 people. So again, talking about a very large sample. And asked the same question. So who among all these kids, and we think now about our range of problems is much broader. We also have substance use problems and all the kinds of things that start happening in adolescence. And basically we have come up with a slightly longer list, but it's still a pretty short list of conditions that have an impact on high school dropout, and leading is ADHD. We also see pretty strong effects of conduct disorder, and then very interesting smoking. So kids who smoke are actually about twice as likely to fail to complete high school on time as kids who don't smoke, controlling for these other factors. So ADHD, again, really comes out very strongly. So where to from here? Can we improve the learning abilities of kids with ADHD? Seems to be a primary focus. Can we improve their education? Can we reduce the impact of learning problems on subsequent problems, which is really a much thornier problem. We can't make everybody above average. You can't make everybody score better than average. we need to try to figure out why it is that kids who start to perform poorly also have other kinds of behavioral and poor decision making, for adverse life events that in particular high school, dropping out of high school. And as Julie mentioned, we need to look at innovative strategies to link pediatricians and teachers. But I'm going to leave it there, and we'll move to the next speaker.
Good evening, and thanks for coming out. I do some research here at the M.I.N.D Institute in ADHD, and mainly in functional imaging and psychophysiology. So I'd like to talk to you about some of the studies that are going on here currently at the M.I.N.D Institute involving brain imaging. And these are all studies that we're currently enrolling. So I'd like to talk about cognition and ADHD, and then eventually move on to some findings of the substance abuse, risk for substance abuse. So the great thing about functional imaging is that it allows us a window into brain activity, so we can give kids or adults tasks to do while they're actually lying in the fMRI scanner, and we can see which parts of the brain are lighting up while they're doing certain tasks. And then when we're looking at clinical disorders, we can compare kids with ADHD, for example, to typically developing kids and see what parts of the brain may be affected. And recently, with the advent of functional imaging, we're discovering more and more that brain regions don't work in isolation, they work in networks, so different regions work together. So that's really important to understand how the actual networks of regions are working together to affect different processes like attention. And I'm going to talk about 3 networks that we're examining at the moment, but this is only part of the research that we're doing. So the first is the default mode attention network, the second is the reward processing network, and the third is performance monitoring network. So the default network, what is that? So these regions of the brain along the midline here, they're regions that when you put a person in the scanner and have them do nothing, just rest, these regions light up in the brain. And they are also engaged when people mind wander and just think about themselves in general or nothing in particular. And researchers also noticed that when you give somebody a cognitively demanding task to do or something that's difficult, these regions are suppressed. And these other regions come online, these more lateral frontal regions and parietal regions. So these regions are involved in control and decision making and those types of processes. And these may be responsible for monitoring your external environment or thinking about yourself. So we conducted a study in 2009 looking at the default network in ADHD, and what we found was that these regions are not being sufficiently suppressed in kids with ADHD when they're given something demanding or something difficult to do when you compare them to control kids. And not only that, this also was related to a behavioral index that we had of mind wandering or distractibility. So the kids that were more distractible were those that were less able to suppress this network. So what does that actually mean in practical terms? Well, it means that the kids are more distractible maybe. So you have the kid sitting at home doing his homework, and if he's not able to suppress the network that's involved in monitoring your environment, then he's going to be more distracted by Facebook and Messenger and the iPod lying on his desk, and he's not going to be focusing on what he should be doing, which is his homework. And when you think about adults and driving behavior, you should be concentrating on what you're doing, driving along, focusing on the road, but you have texting and fiddling with the radio instead. So this is quite an important aspect of ADHD. So the second network is the reward network, and many of you may know that reward processing is altered in ADHD. So individuals with ADHD are more impulsive when it comes to reward, and they also react very well to consistent rewards and quite often being rewarded. Temporal discounting of rewards just means that rewards that are far away, that are distant in time, are valued less than rewards that are right in front of you at that moment. So for example, if I offered you $5 today or $5 tomorrow, most of you would probably take the $5 today. However, if I offer you $5 today and $10 in 1 month, that decision may be a little bit more difficult. Some of you might actually be willing to wait the month to get double the money. In ADHD, you're more likely to go for the $5 today. So they're more likely to take the instant reward. And when we look at brain networks that are involved in these types of decisions, you see two networks that work together. The first is involved in the reward itself, so these regions always light up to rewards. So medial prefrontal cortex, ventral striatum, and orbitofrontal cortex. Anytime you get a reward, these regions fire. Then when you have a difficult decision, like the one I just presented to you, $5 today or $10 in a month, you get these regions coming online, which are again the control regions, the ones that make decisions. They think about it, weigh up the options and think, well, should I take the money now, or maybe it's worthwhile for me to wait a little while. So the problem in ADHD may be that these regions here are overactive, or it may be that these regions here are underactive, or it might be some connectivity between the two regions that are talking to each other. Maybe they're not doing that efficiently. So that's what we're currently trying to work out, and that's why studying networks is so important. In practical terms, again, it means a kid going and blowing their money instead of maybe putting it away for college, or an adult going to the ATM and going on a shopping spree instead of putting it in the bank or thinking about investing towards retirement. These are all impulsive decisions. The third network is the performance monitoring network. And performance monitoring just means when you're behaving in any way, when you're performing any task, it's really important that you're constantly monitoring how you're performing the task to see if you made an error or if you're just about to make an error. So in that case, you might want to change what you're doing so that you don't make a mistake. And it turns out that these regions here are involved in performance monitoring, so in errors or what we call conflicts. So a conflict occurs when something happens in the brain and tells you you're highly likely to make an error in a second if you don't change how you're performing. So we think that when an error or a conflict occurs in the brain, it sends off a signal. And that signal is then passed along to these control regions or resource allocation regions. And they then enforce control over the situation, and that sends signal back and reduces conflict. So again, our studies in ADHD are suggesting that there may be some problem at both of these levels and in the way they talk to each other. So they may have a problem in the performance monitoring part, but also, as Dr. Schweitzer showed you with our ERP results, that they're having problems with enforcing control from the cue data. You saw how they're just not able to use the cue to enforce control and affect their behavior. So this is part of the story. This is problematic as well, and the talking between. So we're currently researching into that too. So an example of conflict is when you're sitting at a red light in traffic, you want to proceed straight on, and there's a left turn signal. I'm sure many of you have experienced that when the green light goes on for the left, you start to roll forward, and then you realize, oh no, it's still red for me, so I have to stop. That's like conflict detection. You're getting two separate signals. Your brain is going, no, I need to stop. I need to step on the pedal before I roll out into the middle of the intersection. So that's exactly what you're doing. You're enforcing control over the situation so you don't make a major error. An error would be if you're driving along and you realize that you missed your turn off, you just have to make a U-turn and come back. So what does all this have to do with substance abuse? Well, it turns out that more individuals with ADHD tend to have substance problems. And also an estimated 10 to 44% of adults who go in actively seeking treatment for substance problems, whether they realize they have ADHD or not, they turn out to actually have ADHD. And ADHD puts you at a greater risk of developing substance problems, whether you've received medication therapy or whether you're untreated. However, there is some evidence to suggest that the vulnerability for substance problems may increase if it's untreated or if you receive inadequate treatment compared to those people who are actually treated. And this is in ADHD without a comorbidity like conduct disorder, for instance. There are also problems with treatment outcomes for people with substance problems and ADHD. So you may imagine the treatment for ADHD is stimulants, so people are very worried about people who abuse substances abusing the stimulants, and there are all sorts of issues that come into play if you have a substance problem and that you also have ADHD. So it's very important that we understand what's going on here. So it turns out that in all the networks that I've described to you, the default network, the reward, and the performance monitoring, it turns out that people with substance dependence problems, they also have problems in these networks. It's not only ADHD. So researchers have found that inefficient suppression of the default network, again, in people who use ecstasy. There's been altered connectivity between the default network regions in heroin users. When it comes to reward, substance dependence is obviously characterized by poor decision making, so people favor behaviors that are rewarding in the short term but have extremely adverse long-term effects, physical, emotional, economical. People who abuse substances tend to have a greater sensitivity to immediate rewards, and there's altered activity in cognitive regions in the type of task that I showed you, the delay discounting, where you offer money now versus money later. With methamphetamine dependence, there's altered activity in these regions, in the cognitive control regions. And there's also altered white matter in adolescents with a risk for alcoholism. So somebody in their family, in their immediate family, is an alcoholic, so they're at high risk of becoming alcoholics themselves. This correlated with how they performed on that delay discounting task too. And then lastly, performance monitoring. Researchers found less midline brain activity. So there are those regions that I showed you before that were involved in performance monitoring. There's less activity there during errors in cocaine users. There's impaired error detection in cocaine users and impairment in trial-to-trial adjustments in behavior. So that's when you experience conflict and you need to subsequently modify your behavior. They weren't so good at doing this. These were methamphetamine users. And our preliminary data suggests that any performance monitoring deficits may be impacted by having an ADHD diagnosis, so it's worse if you have ADHD. And what this means in practical terms is that you have people who are very sensitive to rewards, so they want to do the rewarding thing now. They're not thinking about the consequences. They're not thinking of how it may affect their families or their own health or the economic situation. They're not able to filter out these distracting things and focus on what they need to be focusing on and get where they need to go in life. And then also, they're not monitoring their behavior efficiently, so they may not see the warning signs that they're going down the road to substance dependence really quickly, and they may not realize that. So what we're currently researching, and this is new research focus for us, is are these traits that I've just mentioned, the impairments in these networks in people who abuse drugs, is that a factor that results from them using these drugs for years and years, or is it actually pre the drug use? So do these represent risk factors for becoming dependent on drugs? And do things that these traits that people with ADHD and substance dependence have in common, do they represent important risk factors for substance dependence? And if we find out this question with our research, then it has implications for avoiding substance dependence, not only in individuals with ADHD, but in the population in general. So we can tell people with these types of cognitive impairments are in danger of becoming substance dependent, and we can teach them strategies to avoid that.
Okay, my name's Faye Dixon, and I'm a psychologist here at the M.I.N.D Institute and the director of the ADHD clinic, and I'm also a member of Dr. Schweitzer's ADHD research team, and I just wanted to talk a little bit about some of the current treatments for ADHD and some of our treatment outcome research that we've been conducting over the last year or so. It's been well established that both medication and behavioral interventions are effective in the treatment of ADHD. In terms of what we think of for symptoms and therapy, we have a wide array of treatments that we know are effective, like medication, school support, parent education, and we also have a number of symptoms, and our goal is to really try and match up the symptoms with treatments so that we can offer the best functional outcomes for people with ADHD. In terms of medication therapy, we know that medication is highly effective in the short term for ADHD, but that it has to be maintained with behavioral interventions over the long term so that we can see continued improvement. There's also evidence of impaired brain dopamine activity in individuals with ADHD, often manifested in problems such as working memory and attention and a number of other functions. And research has also established that medication appears to modulate functioning in brain regions that are affected by ADHD, particularly those involving attention, organization, and response to reward. In terms of some of the behavioral interventions for children and teens, we know that parent education is effective, teen organizational skill groups, classroom interventions, and appropriate educational support services. And in terms of adults, we also know that pharmacotherapy, just as with children and youths, work in the vast majority of cases. Pharmacotherapy is often more effective than behavior therapy for adults. However, we do know that behavior therapy has a role and can be effective. And particularly for adults, it's important that we treat whatever co-occurring conditions are present with ADHD, such as anxiety, depression, and substance use. This is a really important study that's come out in JAMA within the past year, looking at the use of cognitive behavioral therapy and relaxation training in adults and ADHD. And what this particular slide shows is that for adults who participated in a study using CBT, that on their self-report about symptoms, that following exposure to CBT, they reported fewer symptoms than adults who just participated in relaxation therapy alone. So one of the things that comes up here at the M.I.N.D Institute is that, patients, parents frequently ask us, what other treatments might be available that are non-medication treatments for ADHD? So one of the things that we've been involved with over the past year or so is that we've been looking at an attention and memory intervention called Med to look at the ways in which it might improve both memory and attention, particularly for kind of homework, classroom settings for children with ADHD. So one of the questions that we're looking at is, could Med be the new black? That is there another intervention that's of a behavioral nature that we might add to our complement of other interventions for ADHD? So one of the studies that was recently completed within our lab involved 26 children between the ages of 7 and 14 with ADHD. It was a randomized, double-blind, placebo-controlled study. And what that means is that neither the participants in the study or the investigators at the time knew who was in which condition. That is, they didn't know, are we getting the active treatment or are we getting a treatment that looks like it's doing something but we're not sure. So that's really important because we want to make sure that the effects that we see are not because there's an expectation about the effect, but because we're actually doing a treatment that is making a difference. So what we had the children in this particular study do was take part in an intensive working memory computerized training, and then following that training, we looked at the effect of non-trained measures on observable behavior in ADHD. And for this particular study, it was using something called the Restricted Academic Situations Task that involved children at the completion of this study being in a room where there might be other distractions in the room, but being asked to do classroom type work such as completing worksheets, working on math. And so as a part of this program, children practiced working memory games each day for about 30 to 40 minutes. The tasks required storage and manipulation of various sequences. The verbal ones might be repeating back a sequence of digits in a reverse order, or the visual spatial tasks might be recalling the location of objects on different portions of the computer screen. The training was adaptive, that is, it started out fairly easy, but then kept matching the child's level of working memory capacity, so that over time, the CogMed training became more difficult. For children who were in our control group, they did the same number of sessions, but the programs that they worked on did not increase in difficulty. We had a psychologist who served as a coach to monitor the progress and provided feedback and encouragement to be able to complete the computerized task over the number of weeks that the children were involved in the study. So then what we discovered at the end was that ADHD behavior decreases only with the treatment. So if you look at the graph here, for the children in our treatment group, they had significantly less off-task behavior and more on-task behavior in this simulated classroom setting versus the children who participated in the program but did not get the actual computerized training. So currently, what we're doing here at the M.I.N.D Institute is that we're conducting another study looking at traditional parent education, which we know is an established treatment for ADHD, versus this new CogMed, which is looking to improve attention and working memory in children. And we're currently recruiting subjects between the ages of 6 and 14 to participate in our subject, and we're hoping, our outcome over the next year or so and in the future is to perhaps be able to add CogMed as, an empirically validated treatment for ADHD, but that research is ongoing, not only here, but certainly at other centers around the country. And then in terms of some of our clinical services here at the M.I.N.D Institute, we provide evaluations of ADHD and other related conditions for children and adults. We do pharmacological evaluations. We provide pharmacological treatment and consultation. We have parent education groups, organizational skill development groups for teens, and in the future we'll be adding adult services that will also focus on groups for organizational skill development.
I'm Dr. Pakurek. I'm from the Department of Psychiatry, and I know some of you. And I think this is a wonderful time to be in ADHD research as well as clinical area. I work with both children and adults, and I was told that I have 30 seconds, so I'll give you a little longer, 45 seconds. I'll give you brief overview about medication treatment as well as some of the clinical experience we have at the clinic. So 2 principles for medication treatment that I would strongly recommend for physicians. It's start low, go slow. It's very important for us to take our time, both for children and adults actually, and to closely monitor the treatment process. For parents who are very anxious about the treatment, medication treatment, it may be worth a try. And various presenters talk about that, and I would like to discuss further. This is a relatively new concept in ADHD. We are very interested in making our ADHD program more family partnered. Family needs to get involved in the treatment process. If you do not get family members fully involved as part of the process, discussion, treatment, you will lose them and the compliance will be miserable. We know this from our clinical experience, but now there is research which seems to be supporting it. The more family members, the better. And we want to listen their stories. We want them to participate in the treatment decision-making process. And we would like to address their cultural or otherwise, perhaps internet based bias or any other thoughts that they may have. If we only work with the core family, a relative who may have significant impacts in family decisions that we're finding out may change the entire treatment process. So we really would like to get those members involved, perhaps educate, perhaps understand their fears better though in the process. It may help us as clinicians as well. Wonderful paper from October 2010 from Bussing and Lal on this. This is just a brief overview of some of the numbers that we recently looked at. 102 children and adolescents at our clinic at the M.I.N.D, 6 adults, 108 total. We have 3 child psychiatry residents, Drs. Lopez, Chuang, and Studdard. We have 2 clinical psychologists, Dr. Schweitzer and Dixon, and myself. We like what we saw, and I'm going to share the results with you very shortly. But these are the main stimulants. I know some of you are very familiar with this list. And at the clinic, we use every single one of these medications for different patients. Non-stimulants, you're very familiar with this group as well. Strattera or atomoxetine is a non-stimulant medication that seems to help with anxiety issues. In terms of alpha-2 agonists, we have Tenex and Intunib, which is the longer-acting one of Tenex. And clonidine, we have longer-acting clonidine form as well. And nicotinic agents are under investigation. We have other medications. I can share the slides with you. If you send me an email through UC Davis website after the presentation, I'll have no problem emailing the slides if you have any specific questions about the medications. But this is very general. Mood stabilizers and antipsychotic medications, including valproic acid, risperidone, and aripiprazole. Also antidepressants such as fluoxetine and sertraline. Again, none works unless you have a good relationship with the family, you understand the family dynamics, family structure, and you have a family partnered process. Some early treatment, 6-month treatment data from those 108 patients that I mentioned earlier. Looks like 87% of them, based on the CSI checklists, physician observations, school reports, and parent-teacher report, about 87% improved moderately to significantly. That's a very good number. We're really happy about that. These are based on 3 and 6 month monitoring. Are there groups with less favorable outcome in our M.I.N.D clinic, M.I.N.D ADHD clinic? Yes. Some of the, it includes some of these patients, adults with inattention and severe comorbid anxiety. Now, some of these patients with their comorbid anxiety, especially if they don't have enough support system, we see that they stop taking their medications. Compliance tends to be limited in this group. And Dr. Dixon mentioned earlier, getting them involved in an adult support group may be the key for this group, for these patients. Patients with cognitive deficits, they will still respond to medication treatment, but it appears to be less favorable than general group. If you have comorbid behavioral difficulties, substance use issues, and mood issues such as bipolar disorder, the treatment may be trickier or response may be less favorable. One or more parents with mood or anxiety disorders may affect the medication outcome. And if there are lots of no-shows for our visits, or if we are working with one parent, but the other parent, perhaps without even realizing or subconsciously working against the treatment process or medication compliance process, that group appears to do worse than the general group.
So who wants to ask the first question?
Thank you all for the work you're doing. I have a question anyone in the panel or maybe several of you would comment on, particularly in the last presentation and as it builds upon the others. It looks to me like there may be a factor in this that could be genetic or could be hereditary. And would you like to comment on that aspect of it and how that obviously makes the whole family history extremely important?
There have been a number of studies at this point, twin adoption studies, several other different methods that we're using. And it's clear that there is a genetic component. Some of the genetic studies haven't been easily replicated, so we're not quite sure of all the components, but in terms of the family dynamics, that can also make a difference. So one, there's a scientific issue about whether or not this is the way ADHD is transmitted, but the other way, and I think this is part of your question perhaps, is what happens if you're in a family and a parent has ADHD, and they're also trying to parent a child who has ADHD. Am I correct? And that's part of the question?
So it's an even larger question, but I'd like a psychiatrist to answer also in terms of what they're finding out about mental illness and brain disease, because it seems to me there's ADHD is a piece of a larger picture.
Well, that's true. There's some comorbidity, so there's other disorders who also have a higher rate of where you see higher rates of ADHD as well. Dr. Pacurak, would you like to?
I think that's a great question. And not only ADHD is very biologically determined condition, but also those comorbid conditions that Dr. Schweitzer mentioned, including mood disorders, anxiety disorders, and others, they are also very biological. Having said that, are there family dynamics that contribute to how the disorder is expressed within a system? Absolutely. Do we see a difference with better school services with these kids? Yes, absolutely. So there are lots of, and the hot topic these days is called epigenetics, the interaction between genes and the environment. Interaction, and when we say interaction, we're talking about the therapy, we're talking about general environment, we're talking about even medications and their effects on the genetic structure. So yes, that's a great question. And that's, I think, one of the reasons that this is a very interesting and very dynamic field right now.
Okay, somebody else with a question?
So I have a two-part question. I'd like to come back to what you were going to say about a parent with ADHD trying to raise a child. I work in a school, and over and over and over again, that's what we're finding. And then I wanted to ask Dr. Dixon how people get into your study that you're looking at.
Sometimes for professionals, the problem is, what do you do about that? Do you raise that issue? There's an issue about whether parents are aware whether or not they have the ADHD, and it's it's a challenge ethically as well. Certainly we know that as many organizational skills that you can teach the parent, that's going to help them be able to better monitor them, make sure that they're following through. But certainly that's something that needs to be taken into account so you can see how good their follow through is. Yes, it's typically not all that good. But if it's possible to start a dialogue with them, there's actually some research by Andrea Cronus Toscano at University of Maryland College Park, where she's looked just at that, where you look at parents who have ADHD, and if you treat their ADHD, if that helps the child, and it turns out it does. So you have to keep that in mind when you're working with parents, to strategize around that.
Oh, and for the parent effectiveness study, that is occurring through our ADHD clinic. That is, parents who have an evaluation of their child and would like to participate in parent education are then given the option to enter a randomized study where they would either begin parent training first or parent education, or be randomized to our CogMed program. So they get both components, but it's a part of a randomized study. Pardon? No, we're currently recruiting.
Mr. Rutledge, if you stand up, this is their graduate students who lead the dissertation project, so he's coordinating that. And I think we get flyers maybe out front for that. So the cognitive training component is a free component. People would typically have to pay anywhere from $1,200 to $2,000 for the cognitive training. And if they participate in the study, that they'll be able to access that for free. So we are definitely currently recruiting for that study. They need to have insurance they can either do self-pay or whatever, they would need to call the M.I.N.D Institute new patient coordinator and check with them, and they can help them work through that process. So they would have to pay for the cognitive training, for the parent education groups.
Hi, I have 2 questions. One is the patients who you see here, are you mostly seeing them on sort of a short-term basis? And then my other question is, what sort of research is being done on the interplay between sensory processing issues and ADHD? That's a big issue in my family.
So I'll handle the sensory processing, and feel free to jump in and you can handle the question about the services. So in terms of sensory processing, we aren't specifically looking at that here, but it's very clear. If you look at our studies, we see over and over again that there are regions of the brain that are involved in sensory processing that are implicated, much more so, and that you find that people with ADHD tend to use those regions of the brain more than they do the areas of the brain that are involved in attention and executive functioning. And we have a hypothesis that these are compensatory strategies, that they're using that instead. So one would think that has to affect their everyday functioning. So it's something for us to think about in the future, about how to approach that and what the outcomes would be in terms of how people do function in every day. I'll let Dr. Dixon answer the question about the clinical services.
Yes, our clinic has been conceptualized to be a short-term evaluation and intervention clinic, so that we're able to offer an evaluation and then perhaps short-term medication therapy and consultation, as well as our parenting and our teen organizational groups, with the idea that after the child has been stabilized, that they return to their community care. Except.
Kind of control my mouth. So we do have this model also because we do know that ADHD is a chronic disorder for most people. It's similar to diabetes, that you need to keep the insulin going, and it also changes with development in terms of how the behavior and issues are expressed. And so once somebody has graduated from the parent education training, and they've probably either maintained either here or someplace else in terms of pharmacotherapy, they can come back for consultations. And we're interested in doing a model where they could come back maybe once a month or something like that for tune-ups, and just to stop by and have a session with us to focus on how maybe we could tweak things, to give some suggestions and so forth for what seems to be the issues at the time. So that's our model, because again, we know that once the child, for instance, if we see an 8-year-old, by the time they become 16 and start driving, there's different hosts of issues. When they're in middle school, it's a different host of issues from elementary school. And so we need to help parents in terms of how they can address development and so forth.
Okay. I have 2 rather different questions. One is I'm intrigued with the nicotine mention and wondering if smoking is perhaps a sign of self-medication, or if nicotine might actually help treat ADHD. The other question is, have you explored the use of dialectical behavior therapy in the treatment of ADD or ADHD?
Well, I'll say something about the nicotine issue. It's at least from the epidemiologic side, the treatment side, dealing with nicotine as potential medications that might involve nicotinic receptors. I'll let the psychiatrist deal with that one. What we find is that the kids with ADHD are at higher risk for dropout. The kids who smoke, whether or not they have ADHD are also at higher risk for dropout. Whether there's a relationship between those two, we can't say. It seems to be basically pretty much two independent things. And the main thinking with respect to the impact of, or the association between smoking and dropout is that smoking is kind of a good marker of kids who are already kind of on a negative educational trajectory. And it's not necessarily that the nicotine or smoking is having an impact a bad impact on their schooling. That's, I think, the main idea. Now, whether, but it's still a possibility, say, that kids who have nicotine dependence are really suffering in school because they want to go out and have a cigarette, and that's a distraction and it is affecting their schoolwork. To some extent, that might be going on as well. But right now, I think we think that those are kind of independent things.
Just one comment about the question too. Recent, I think it was published this week, a paper suggested that there is a strong correlation between ADHD and adolescent smoking. It's a very strong, and adolescent and adult substance use. So we know they are closely connected now. I read the article yesterday, but I believe it was just published. In terms of the receptors and the new medications, we are very hopeful that this may be, it may not be a major avenue, but it will definitely be a new, looks like based on the preliminary studies, it may be a new area with a small group of medications, and there appears to be some movement in that area. However, I don't think we are any close to having a medication for us to use within the 2011. But there are initial studies that appear to be promising.
Oh, and I think there was a question, I guess the other part was about DBT, and that is not currently a treatment that we're offering here. Are you talking about that in reference to adults as a part of an adult package?
I was just interested whether it would be an effective approach, since it seems to be being used for an increasing variety of problems, including substance abuse and so forth.
I was going to say, I have not read much treatment outcome research about it in terms of ADHD. I don't know if anybody else has.
There's definitely increased interest on DBT in using DBT in wider areas. This is dialectical behavior therapy, and initially it was in only one area. Now that's getting wider, so that's a very good question. I'm not aware of any reliable studies, however, that will connect DBT as a valuable tool for ADHD in children or adults at this time. But Dr. Dixon mentioned earlier, there appears to be some early promising data on CBT and ADHD group.
Hi there. So during your talk, you guys mentioned a wealth of evidence regarding the neuroimaging differences between those with ADHD and typically developing children, which I find very fascinating. And I was wondering if you guys have any thoughts or comments on maybe this isn't financially feasible, but perhaps on using functional MRI as an objective adjunct to the arguably less sensitive DSM criteria.
That's
For
a great
diagnosis. For
so-
diagnosis?
Yes, that's a great question. There's a number of us throughout the country who have been doing functional imaging for some time and structural imaging, and I think at this point we feel that we're not at that point. We feel pretty strongly about that, actually. The long-term goal, I mentioned that there's this Connect to Known project that we're doing, where we're looking at starting with a sample about 200, but our long-term goal is at least to have 1,000 participants enrolled. Something potentially might come out of that. And initially, what I'd say is, as I said earlier, maybe some subtypes, and to look at how we could develop treatments along that line. In the long run, we're not quite sure what imaging would add. It would depend. Those data where I was talking about are resting state data. They're actually fairly quick to acquire. We can acquire it between 6 to 11 minutes, so it's pretty short. But also imaging is a very expensive tool. And there are a number of times a child or an adult can come into an ADHD clinic, and you really don't need imaging. It's not necessarily that helpful. And at this point, it doesn't really add anything beyond what we know. So if we ever do get to the point where we do use it, we'll still need to do rating scales and interviews and so forth, because that will just provide us part of the picture. So at some point down the road, it might be there, but we're quite a ways away from that. And I think when it will be useful, again, is maybe for looking at subgroups, but also there are individuals, ADHD is a very common diagnosis. And most people, when they mature, when they grow up, they continue to have ADHD, but every once in a while, you do get somebody where it's an early predictor of some other disorder. And there are some other disorders where you would really want to intervene. You might want to intervene in a different way. That's where I think really, that's where imaging has more potential. But that means also not just looking at lots of people, but looking at lots of people over time so you can figure out where they diverge and become some other disorder.
Okay. During the presentation, there were several components that were listed that needed to be present to bring it to a positive outcome for the child or the adult. Mainly for children is what I'm focusing on. One of those being organizational skills, another being an involved family, all the family members that might have an impact on this child and the regime that was put in place. And the third that was mentioned was educational supportive services. And I was wondering, for the parents and the children that are participating in your study, how is the school then pulled into it? Because that's what I need, is the language to ask the school to help me.
Well, that would be particularly a part of our clinical services, where we work with families to help them to come up with better strategies to engage their school, how to find out what services their child might be eligible for, and then to help them to manage working with their school to try and obtain those services.
Hi, just a quick question about the clinic. What percentage of children that are in your program have comorbid diagnoses along with the ADHD?
We just started looking at the data, and I presented to you for the first time, actually. We will continue to work on that, but looks like the group of patients that we are working with, they are usually referred to us, the majority of them, through primary care providers. And sometimes this group may have a selective bias, meaning that perhaps these are at least initially more resistant to treatment or somewhat more complex cases because of the specialty that M.I.N.D Institute represents. However, we also have brand new patients. So we are looking at comorbidity in our group as a general group, as well as perhaps difference between second or third round treatment referrals versus brand new patients coming into treatment for the first time through M.I.N.D Institute ADHD clinic. But if you look at the existing data in terms of comorbidity, I think our clinic will be just like any other clinic overall, which means very high comorbidity in terms of behavioral difficulties, mood and anxiety disorders, learning difficulties. These are usually bright, wonderful, bubbly kids, but we also try to see those perhaps more underlying difficulties that may be creating further issues, including social difficulties that Dr. Schweitzer mentioned earlier, reading nonverbal cues, etc. Any other comments?
I think it was Dr. Dixon in her presentation mentioned the word something about relaxation therapy, particularly as it relates to adults. If I got that correct, what is that? Is it available here at the Institute, or where does one get more information on it?
I was going to say, yeah, it's not something currently available here, but it was one of the comparison treatments to cognitive behavioral therapy in the study that was conducted a number of years ago by the Saffron group. So, yeah. So it's not currently available here.
But it's also not as effective. Right. As it showed as a control group, that wasn't as effective as a cognitive behavior therapy. So the relaxation training, if there's an effect, certainly wouldn't be the first choice. The cognitive behavior therapy would be a choice over that.
I had 2 questions. The first is you're studying, I guess, comorbidity. Have you seen any link between ADHD and giftedness? That's the first question. And the second one, and the 2 nights I've been here, you've kind of kept encapsulated both aspects of ADHD, the inattentive and the impulsivity and hyperactivity. Are there any distinctions we should know about in terms of either brain function or behavioral treatments among those?
So should I start? Okay, so I'm going to answer the second question first because that's a particular area of interest of ours. We think, especially Dr. Fassbender and myself, who've been working on this for quite a number of years now, that there are distinct differences between what we call the inattentive type and another subtype, most commonly the combined type, where people have hyperactivity, impulsivity, and attention, versus inattention, where people are more daydreamy, more difficult time focusing. So the data that I showed suggested that there's more similarities between the combined and the inattentive type, but we have other data that suggests there are some behavioral differences. We've done study actually in children and adults suggesting there are behavioral differences, and we think that there are neural differences. I presented the ERP data, but there's also data, other brain imaging work that we're doing. So we think it's different. There's been very few studies actually looking at the differences in treatment effects. But the few studies that have been done, last count there were only 3 in the past 20 years, suggested that people with inattention did better with lower doses of stimulant medication, whereas a combined type is a more linear effect. The higher the dose, the better you do. And instead, if you just have the inattentive subtype, you tend to do worse after a certain point as you increase the dose. There was actually a movement in DSM. So DSM is our manual for diagnosing psychiatric disorders. And they're working on the new one, DSM-IV, and they were talking about dropping subtypes. And last I heard, they had changed their mind about that, which I'm glad to hear. I think that they're actually 2 really distinct disorders, and I think it's not helpful to call them both ADHD because in their flavor, they're just so different. They're just really different people. And we can see in a scanner, they're very different. So when we scan people with the inattentive type, they lie very still. They're probably daydreaming, but they give us beautiful data. Because when you move, it's like any sort of camera. When you have movement, it distorts the data. And with our combined type, there's much more movement in there. Anything else you'd like to add?
I'd just like to add that although we have some fMRI data looking at the same paradigm that Dr. Schweitzer presented with the cues from the ERP data, and it's very preliminary, but for now we're finding that they're actually activating very different brain networks. So they're definitely, from the fMRI data, it seems that they could be 2 distinct processes involved. So.
I think it was about the relationship between giftedness and ADHD. And what we know, certainly in the research, is that ADHD children have a wide range of cognitive abilities. And although we do know that learning differences do occur at a much higher rate with children who have ADHD, but I have not seen anything specifically that says giftedness is directly linked with ADHD.
I would suggest parents are more frustrated. Because we see a number of children and adults who are gifted. We see so many people who are so bright. And I think this is one of the challenges for people, for teachers as well as for parents and for the individuals, that they can do so well in some areas.
and have such tremendous strengths. In other areas, they have such challenges. And some of that goes to some of our other research on variability, where we see from day to day and even second to second, people with ADHD are more variable. So I'm also wondering perhaps if it's even more striking when you do have people who are gifted. Although the fact that they use different brain regions to process some tasks suggests maybe someday there should be a study looking at that. But.
We have a first part of the question. We have a group of patients that they present. If you follow them longitudinally, they present as a very comorbid ADHD, a very combined ADHD with lots of hyperactivity, impulsivity, in addition to inattention. You follow these patients 8 to 10 years, and then as a young adult, they present as an inattentive ADHD. They may still have some impulsivity perhaps, but hyperactivity may be gone, so that may be another interesting thought to just comments that were made earlier.
I was wondering, do you offer any services for behavior issues on neurotypical siblings of ADHD patients?
Oh, what kinds of services, I guess, specifically, or what do you?
Well, my older son has ADHD, and it's perhaps not the best role model for my youngest son, who has some behavior issues, or when he is in particular around his older brother. And I was just wondering, with all of the family partnering that you're offering, has there been any thought given to offering services for neurotypical children who are siblings of ADHD patients who might also demonstrate some behavior issues?
I see. Okay. Well, certainly I think those are the types of issues that we would like to address through our parent education and support groups, because we do discuss that, because that does come up in our parent education groups, because you've got one child who perhaps is exhibiting a number of hyperactive and impulsive symptoms, and then a typically developing sibling, who is reacting to that as well. So that is certainly something that we try and discuss and provide strategies for within the context of our parent education and support group.
I was wondering if there was any plans to offer a social skills group for elementary age children with ADHD.
So far, research does not support the efficacy of social skills groups for children with ADHD, because the difficulty with ADHD kids is not so much knowing the social skill to use, but the timing of it and how to appropriately call upon it when they need it. So unlike other conditions where there may be more of a deficit or an awareness of the skill in general, it may be in the repertoire, but it's when to use it at the appropriate time. And so it is actually more effective to deal with social skill issues with children with ADHD within the classroom context or within whatever social group context they're in.
I'm told I may be the last one. Sort of two questions. I'd be interested in knowing what you foresee in, say, in the next 6 months in regards to your adult services, and also what you see in terms of research as adults progress. So how does the disease symptoms tend to progress as adults age with ADHD? Thank you.
I'll try and talk about the services part. What we're hoping to begin over the next several months would be a group for adults where we're dealing with things like time management, organization, remaining on task, because for most adults, they're either in college, graduate school, out working in the world, so we want to have a group that addresses the types of skill that you need both to manage your professional life and to manage your personal life. So actually a real sort of skill building and also support group as well. So I'll let Dr. Schweitzer talk about.
Okay, all right. I think that's an excellent question also about the development of adults with ADHD and what we see. And people are just starting to look at that. There are a number of studies where they're There's several retrospective and some prospective now. And I think the oldest they've gotten through is probably the 30s. But I think it's a great question. And I don't know of any studies, as I said, ongoing at this point that are looking at older. But we've been talking about this in our laboratory about what a fascinating question. And to look at outcomes and so forth. And so that's a great idea. So we're always looking for ideas. So that's a good one.
I have two questions. One is the genetic study that you did here or participated in. Is that posted on your website, the results of it?
The gene
Sharp?
expression one?
Yeah.
So that was a dissertation for Dr. Lisa Litt. So that particular study, she has not published yet, but they're continuing to collect data on that study. So they have a number of samples, and they're continuing to work on that. We're actively writing grant applications to try to get funding for it, to be honest. But that's an ongoing study, and we welcome people to, if they're interested, children and adults.
Well, my daughter was in it, so
Oh, good. Okay.
wanted to see the results.
Thank you. We appreciate your
Trying to get her
involvement.
twin brother to accept $100 for drawing blood, but he's not taking it yet. And then my second question was for Dr. Breslow, and I don't know if you can answer it, about education and inattention. And you said that as kids got into high school and improved their memory, things changed. I want to know how they improved their memory.
How they improved the memory? Well, in this study there was no intervention. We were just looking at, it's fairly stable in attention scores kind of throughout this age period, but there are some people who go up and some people who go down. And the fact that this change was associated also with change in achievement really supports this idea that, they did something. Maybe if we can mimic that, we can do that through an intervention. We can also have the positive downstream effects as well. So it is an encouraging. I think you hit exactly on why that's interesting and important is that it indicates there may be a way to positively influence the whole system. So.
I was going to say, and I would just add to that, that certainly research suggests that educational intervention, behavioral interventions, and probably pharmacological interventions may have been a piece of what led to that later improvement.
Oh yes, I don't know if I'm the last one, but I had a question. One thing that's always stuck with me when I was learning about ADHD is the higher prevalence in minorities. And I was wondering what multicultural aspects you use or have learned in conducting your research on ADHD.
I'm not sure about whether there is consistently actually in our epidemiologic studies a higher prevalence in minorities. I think there is, without question, there is lower treatment, and minority groups are underserved and have less access to care, are much less likely to be getting treatment. So they're probably much less represented in clinical populations. Whether there are differences out in the population, actually in the incidence or prevalence of the disorder, I think is less clear, and if they're probably much smaller than the treatment differences. So.
Yeah, I believe that there was a Surgeon General report out about 10 years ago actually showing that there is not a significant rate in the population more in minority populations of ADHD, and that the difference has to do with the availability of treatment and the availability of appropriate diagnostic treatment. So that's where the difference occurs. But if you look across the entire population, you're actually not seeing those kinds of differences.
In terms of the working with different cultural groups, cultural psychiatry is just beginning to get involved in research studies with children and adolescents. It was very limited to adults. So I think that's a very hopeful sign that we are going to see, in fact, we had recent grant rounds on this, we are going to see more and more funding and newer studies about these groups.
Okay, so thank you all. Thank you to the panel. Thank you to the audience. Great questions.
The UC Davis M.I.N.D Institute began in 1998 with a promise to find cures for neurodevelopmental disorders. Every day, our physicians and researchers come closer to fulfilling that promise. Their groundbreaking research on autism, Fragile X syndrome, learning disabilities, and other brain disorders is helping children achieve their fullest potential. Please call or visit our website to find out more about current studies, our research team, and upcoming events.